that all this time I've been wasting your time by telling you whether or not it's a good morning, good noon, good afternoon, good evening. And I realized, what is one term that can capture it all? And here we are on VMR 358. I just made that number up. I think it's a guess, probably more. We found a simpler way of saying all that. Good day, y'all. Good day. It's great to see you all. Happy Friday. There's a beaming smile coming from many videos today, but Sukriti's smile really is very infectious. I'm making her smile even more now. I'm a little bit out of embarrassment. We all witnessed the incredible discussion yesterday by Sukriti and Kirtan, who are both here today. But the case presenter, Rafa, is uniquely positioned to reflect on the case, both because I want to embarrass him and because I thought that the way he did the teaching points yesterday was masterful, and I think we could all learn from it. He is going to try to pass the mic to Tiago, who is an endocrinology expert, but I'm going to veto and block that because we all want to hear from Rafa. So before we do, though, before we are bamboozled by the wisdom of Rafa Medina, please jump on in and present a case. We are Sans magician today because he is on service taking care of 8 new patients as of this morning. Which is a lot. So please volunteer to present a case. We would love to hear it and discuss it with you. And I'll pass the mic to Rafa to reflect on yesterday.
Thank you, Robbie, for the kind words. And good morning, everyone. Good afternoon, good evening from wherever you are. And just a shout out to if there's a case presenter, we need just one case. And so yesterday's case, I presented the case about a 55-year-old man with abdominal pain and weight loss. And then first we talked about the abdominal pain. Every time that we see a patient in that setting, we have to rule out emergencies. Many of them including, for example, perforation or obstruction, and also creating reminders that we always have to look about comorbidities that the patient may have. For example, if this patient had atrial fibrillation, we have to think about acute mesenteric ischemia. And then we saw that this patient had several symptoms besides the abdominal pain and weight loss. This patient also had nausea, anorexia, and also he had dark spots in his hands and his face for 1 month, and intermittent distal numbness of both hands and feet. And we thought about many causes that could lead to that. We thought, for example, adrenal insufficiency that could be leading to the hyperpigmentation. We thought about vitamin deficiencies that could also explain the autonomic neuropathy that this patient was having. And then Charmaine reminds us that when we're dealing with the abdomen, we have to think about the neighbors of the abdomen. And I really enjoyed that pearl. And we thought about, for example, ACS, pneumonia, pulmonary embolism. And if this was a female, you had to think about pelvic pathologies, for example, ovarian torsion or ovarian cyst or ovarian cancer, or also PID or endometriosis. And then rabiectomy, that we can think about a constipation divided into 2 buckets, which can be obstruction, for example, neoplasia, volvulus, small bowel obstruction from adhesions, but also neurodysfunction, autonomic neuropathy. And just to remind that this patient had paresthesia, so we could see a neurodysfunction in the both setting due to the vitamin deficiency. And then finally, we saw that this patient had autoimmune gastritis, pernicious anemia, and also a low cortisol level in the morning. So we had to combine autoimmune gastritis and adrenal insufficiency, and we came up with polyglandular autoimmune syndrome. And I think the biggest takeaway from me that Ravi taught us is that every time that we see an autoimmune disease that we can't figure out what is happening, like it doesn't fit the illness script at all, we have to look at another possibility, at another autoimmune disease going on. And it's the same concept applies for opportunistic infections. Like if there's an opportunistic infection that it doesn't fit your illness script and there's something else going on, you have to look for another. So thank you, everyone. That was my reflection.
Absolutely brilliant. See why I told you to do it? Oh, that was so good. So good. Thank you, Rafa. We actually had an interesting thing happen in the chat. Sabih had actually directly messaged us and asked, and actually has a case to present. But it looks like, I don't know, I actually wasn't looking at the chat at the same time, but it looks like Sharanya also has a case. So Sabih, if you wouldn't mind, might ask you to hold on to it and present it next time if that's okay with you. But we would love for you to unmute yourself and introduce yourself to everybody before we say goodbye.
Sure. Yeah, it's absolutely fine. Hi, it's nice to meet you guys. Yeah, I actually didn't know if I was supposed to do it on the regular chat.
Yeah, that's okay.
Yeah, but it's nice to meet you guys. I'm looking forward to hearing what the new case is.
Incredible. Tell us more about yourself.
So I'm a first-year resident intern, I guess, going into second year. I live in Massachusetts in Springfield, and yeah, that's
incredible.
I used to live in the Middle East. I'm Australian, but also Bangladeshi. Kind of complicated, but
wait, what? No, you gotta tell us now.
Yeah, so I'm an Australian citizen, moved to the Middle East for college, went to Cornell Medicine in Qatar, and then came to Bay State for residency.
Oh, that's so cool. Bay State. Oh, we have a lot of CP Solvers has been lucky enough to work with Bay State in many ways. And then you in the Middle East, you were in Qatar. Is that where you were?
I was, yeah, for the first 2 years of med school, and then I was in New York for the rest of it.
Is that how it works? Like you do pre-med there, and then you do your clinical rotations in Cornell?
It is really, it's a really complicated system, but yeah, the first 2 years of pre-med is in Qatar, and then for the next 4 years of med school, it's 2 years in Qatar, where you do your clerkships, and then you do your elective sub-Is in New York, and then research kind of where you want to.
Got it. That's so cool. That's fascinating. Well, thank you so much for joining us, and I can't wait to hear your case hopefully in the near future.
Sure. Yeah. Looking forward.
Awesome. Sharanya, thank you so much for volunteering.
Hi. It's my first time here, so thanks.
Oh, of course.
And I'm really sorry about I just finished my 4th year of medical school in Bangalore. I studied in Bangalore Medical College. So I just started my internship last week.
Incredible. What are your internship in?
Internship is like a 1-year compulsory rotation in all departments. So right now I'm in OB-GYN.
Okay. And what do you want to do after your internship?
Internal medicine, most
likely. There we go. There was only one right answer. I'm kidding.
Yeah.
I'm glad you selected it. Do you happen to know the legendary Sukriti, since you live in the same city?
Yeah, I was here yesterday. She was discussing.
Yeah. See, I made her smile again. That's my goal. Well, incredible. Thank you so much for joining us. I can't wait to hear your case. Jump on in. We're ready whenever you are.
All right. Okay. So here's a 16-year-old male patient who presents with a 1-month history of fatigue and reduced appetite. And he also complains of yellowish discoloration of his eyes and skin since 8 days. And on further questioning, he's had dark wine-colored urine. And you want me to stop here or go on?
I think
okay. There's no history of.
I think that I think there's to be honest, this is a great place to reflect. And I think it's funny how as you were describing the case, the clarity on the root of the problem starts to emerge. But if you start with fatigue and reduced appetite, there's really almost no diagnostic progress that you have. And what fatigue and appetite is they're analogous to sinus tachycardia. The worse they are, the more concerned you are, but unfortunately you have no specificity as to the nature of the problem you're worried about. So if you just get an EKG and the EKG in front of you says sinus tachycardia, you have no information apart from the fact that you need to worry about the patient. And that is also true of fatigue and reduced appetite. You have no data apart from the fact that these are alarming symptoms that prompt concern. So then you get a lot more specificity, and the yellowish discoloration is actually very specific and tells you that the patient has hyperbilirubinemia. And a quick plug on hyperbilirubinemia. There are 2 organs that help us excrete toxic products from the body, and that's the liver and the kidney. And let's just face it, this is a little controversial, but the liver is way better than the kidney. Let me tell you why the liver is better than the kidney. By the way, I'm so glad Reza's not here because he totally loves the kidney more than liver, and he would kill me right now. But I'm going to say it louder. The liver is better than the kidney. Why? When I tell you that your patient has kidney dysfunction, I tell you that in the form of an elevated creatinine. And you're like, oh, okay, the patient has an elevated creatinine. I have no idea if it's pre-renal, intrarenal, or post-renal. No idea. I have to study many other things to be able to tell you, is it pre, post, or intra? And the truth is that I would use the base rate to prioritize prerenal, but I don't really know that. The liver doesn't lie though. The liver is smart and selectively identifies pre-hepatic causes. What do I mean by that? If you tell me what the bilirubin is, direct or indirect, I've made a tremendous progress. I divide hyperbilirubinemia. Are you kidding me? No, I'm not. This is why this chat is just too smart that I have to actually minimize it. But I encourage you to divide jaundice like you divide creatinine elevation. Is it pre-liver, intra-liver, or post-liver? What's pre-liver? Pre-liver refers to the accelerated accumulation of indirect hyperbilirubinemia. Intra-liver refers to a dysfunction of bilirubin formation and excretion within the liver parenchyma itself. And post-liver is no different than post-renal. It is a disorder of the system that collects and excretes bile. So if you close your eyes, I want you to picture bilirubin as pre-liver before it even makes contact with the liver, in the liver itself, and then in the excretory mechanism, like AKI. But why is Billy better? Billy's better because Billy rhymes with better and tags itself as prehepatic. So you don't have to worry about distinguishing prehepatic from intra and post because the nature of the bilirubinemia does that for you. I wish that there was an indirect and a direct creatinine. I wish. That would be amazing, but that doesn't exist. So you never have to worry about pre versus intra and post. What you have to do is make an educated guess before you get that data if it's pre, intra, or post. And often the tension is at intra or post. So here, let's try to make an educated guess. Is this direct or indirect hyperbilirubinemia? The truth is we'll know soon, but direct bilirubin makes it into the urine and darkens the urine. That prioritizes here direct hyperbilirubinemia as the cause. Two caveats. The problem is that the most common cause of dark urine is nothing to do with bilirubin. It's the fact that when people get sick and have reduced appetite, they concentrate their urine. So the dark urine may be completely nonspecific. But here's the bigger problem. The most, I would say, the fanciest cause of indirect hyperbilirubinemia, indirect, which does not make it into the urine, is hemolysis. Hemolysis can cause, independently of indirect hyperbilirubinemia, the presence of hemoglobinuria, which pigments the urine. So let me summarize. Jaundice equals prehepatic, intrahepatic, posthepatic. Intra and post are direct hyperbilirubinemia issues. Pre is indirect, which is why Billy is better. It tells you where the problem is to some degree. If you're trying to guess before the lab is back if it's indirect or direct, the dark urine is helpful and prioritizes direct hyperbilirubinemia because the direct bilirubin is soluble and makes it into the urine. But the dark urine may be true and unrelated because a lot of people get sick and concentrate their urine and that makes it dark. Or most concerningly of all, you have indirect hyperbilirubinemia from hemolysis, and the indirect bilirubin is not making the urine dark. It's actually the hemolysis in the hemoglobin, which is a very scary picture because that tells you that there's a lot of hemolysis going on. So the key question now is, what is the bilirubin and how is that going to help us make progress? Is it direct or indirect? And after we understand that if it's direct, which it probably is based on the dark urine, we'll have to study some features to help us make it intrahepatic or posthepatic, and we may or may not talk about those. All right, back to you, my friend. Tell us more, please.
All right. So there's no history of weight loss, no history of itching, no history of drug intake or blood transfusions in the past, no similar family history, no history of heavy metal exposure, and past medical history is insignificant. There were no similar episodes in the past. He doesn't consume alcohol or drugs or doesn't use tobacco, and he has no allergies. Should I go to the vitals?
Please.
Okay. So his temperature is 97 degrees Fahrenheit. Heart rate is 82. BP is 118/78. Respiratory rate is 19. SpO2 is 98. On examination, there's pallor and jaundice, and there's mild hepatosplenomegaly, firm and non-tender hepatosplenomegaly. Neurologic examination was normal. Cardiovascular and respiratory system examination was also normal. No stigmata of chronic liver disease or any signs of cholestasis. And should I stop here?
Yes, this
Before
is
we,
wow.
yeah.
I can see why you were jumping in to present this case because, whew, wow. The liver and spleen are big. It's never a good thing when the liver and the spleen are big. We talk about splenomegaly much more often than we talk about hepatomegaly. There are a couple of reasons for that, but let's talk about why the spleen may be big. At the end of the day, if you could zoom in on the spleen and study it microscopically, you'll see that it's big because of one of three reasons. The spleen is big because it's full of water from passive congestion from portal hypertension. It's full of microscopic molecules like amyloidosis or lipid storage diseases like Gaucher's disease. Or if it's not full of water or molecules, it's full of cells. What kinds of cells? Two types, red blood cells or white blood cells. So really the spleen is big because you have too much water, too many cells, or too many molecules. Water refers to the presence of portal hypertension, which you would see on exam. Portal hypertension rises to the surface of the body. How does it do that? It makes the superficial abdominal veins dilated and the belly big by filling it with fluid. And here, the lack of caput medusa and the lack of ascites makes portal hypertension less likely, knocking off the most common cause of splenomegaly. And now we are in the world of molecules and cells. The cells are red blood cells and white blood cells, and the red blood cells are a reminder that chronic hemolytic disorders, be it from an infection like Babesia or malaria, or congenital like sickle cell disease and hereditary spherocytosis can make the spleen big, but also subacute hemolytic diseases like autoimmune hemolytic anemia can also make the spleen big. The good thing about the red blood cells is, unlike the white blood cells, the red blood cells leave a signature within the blood in the form of overt hemolysis. Everything that I just mentioned, you'll assume that the spleen is filled with red blood cells because you will see the damage of those red blood cells on the peripheral smear and through a study of markers of hemolysis. The white blood cells are not so kind and don't leave a very unique signature and span a range of infectious, autoimmune, malignant, drug-induced, and primary hematological malignancies. Kushal was kind enough to post the schema in the chat. You'll see the white blood cells have 5 different causes: infection, autoimmune, malignancy, drug-induced, and the myeloproliferative neoplasms. In a young patient, you have to entertain the possibility of liposomal storage diseases like Gaucher's disease, especially when there's evidence of another enlargement, and that's the liver. So what does the liver enlargement tell us? Whenever the liver is big and the spleen is big, you wonder if the liver is driving the splenic process through portal hypertension, but that's not the case here. The liver can also be big by the same accumulation of the same molecules we talked about, amyloid, lysosomal storage diseases. The liver tends not to be big with red blood cell disorders. So we've talked about hemolysis and hemolytic anemias. They don't usually make the liver big. Infiltration of the liver, though, with white blood cells can occur. So if you're studying splenomegaly, you'll say the following. It's either big because there's too much water, there's red blood cells, white blood cells, or molecules. The water hypothesis is much less likely because there's no other evidence of portal hypertension. The red blood cell hypothesis is less likely because it tends not to involve the liver, though there are exceptions to that, like sickle cell hepatopathy. So now I think the key question is to prioritize white blood cell infiltration of the liver and spleen, of which there is an extensive differential diagnosis, or congenital issues. We have a very high likelihood that this patient is anemic based on the pallor. And the question is, does the anemia help us prioritize between the most important thing, direct or indirect hyperbilirubinemia? And the answer, unfortunately, is no. Anyone who's jaundiced from a direct hyperbilirubinemia to this degree has many reasons to be anemic independent of hemolysis. If your liver goes down and your spleen goes down, you're going to be anemic from sequestration alone. So unfortunately here, the anemia does not provide specificity to tell us if it's hemolytic or anemia of sequestration or other forms of disease like anemia of chronic inflammation. So let's summarize. We mathematically, without doubt, proved that Billy is better than creatinine because bilirubin tells us with specificity if it's pre, intra, or post. We still have that tension unanswered because despite the fact that there's signal towards the liver with it being big, prioritizing direct hyperbilirubinemia, there's also signal towards indirect with the fact that the patient's anemic, but both those signals are non-specific. We know the spleen is big and the liver is big, but the connection between them, the portal vein, is unlikely to be on the hook because there's no water in between. There's no ascites and no caput. So they are likely independently big rather than big because of each other. What could they be independently big from? Accumulation of molecules, cells, like red blood cells or white blood cells. And I think the key question is, what is that bilirubin? That'll help us make tremendous progress. And I'm excited to hear the labs next. All right, we're ready whenever you are, Shania.
Oh, I'm sorry. Yeah. Okay. So we did the hematological investigations, and his hemoglobin was 6 grams per DL, and total WBC count was 5,000. Platelets were 150,000 normal. MCV was 101 femtoliters. Reticulocyte production index was more than 2.5. Direct Coombs test was negative, and his blood sugar was 110. Urea was 12 milligram percent, and creatinine was 0.72%.
I'm so
Total
sorry.
bilirubin.
You might have to slow down a little bit for the scribe to catch up. That's okay.
I'm so sorry.
No worries at all. You see Secretius scribing right as you speak, so you might have to slow
I'm
down.
so sorry. I didn't realize I was.
That's okay.
Okay. Should I go over this again?
Yeah, maybe just to hear it one more time. That would be very helpful.
Okay. Hemoglobin was 6. Total WBC was 5,000. Platelets were 1.5 followed by 4 zeros. Okay. MCV was 101. Reticulocyte production index was more than 2.5. Coombs was negative. Glucose was 110. Urea was 12 milligram percent. And creatinine was 0.72. Okay, total bilirubin was 4.5. And indirect was 3.8.
Prehepatic. Sorry.
AST was 70. And ALT was 40. Albumin was 4.3. And globulin was 2. And INR was 1.2. LDH was 2,000. There's more. Should I go on? Or
I think this is you've given us a lot of very juicy information to work with. And I think this offers definitive proof that the liver is better than the kidney. Look at that. Like, you now know this is prehepatic. You have it's just pre-renal, post-renal, intrarenal, none of that. It's prehepatic. The causes of indirect hyperbilirubinemia, now that we have time to spend on it, really collapse to 3 different categories. Is there increased delivery of indirect hyperbilirubin as a result of hemolysis or as a result of a hematoma? So there's too much going on. That could be happening for sure. Or is there impaired conjugation that occurs because of vascular disorders like congestive hepatopathy or portosystemic shunts? Or is there impaired uptake? And that impaired uptake can be the result of medications that we give, like atazanavir, can be the result of hyperthyroidism, which is a fascinating mechanism, and most commonly the result of Joubert syndrome, which is a non-specific, which is a common enzymatic defect that impairs the conjugation. So if you're really trying to study indirect hyperbilirubinemia, the question often is there something else going on systemically or not? Isolated, clinically silent indirect hyperbilirubinemia is Joubert syndrome. Usually the patient comes into an outpatient clinical visit, has nothing else going on, and has a mild indirect hyperbilirubinemia. Indirect bilirubinemia with some action elsewhere makes the most common cause, Joubert, unlikely, and shifts the focus on the rest of the schema. Here, we have evidence of anemia. And the question is, what is the cause of the anemia? I'm going to try to introduce a new concept and tell you how you know for sure that this is hemolysis in some maybe more simple terms. What does the LDH mean? LDH means that there are some cells in your body that are bursting open to a tremendous degree. So if you see an elevated LDH, you know there are some cells in your body which house lactate dehydrogenase inside them that are bursting. And your job is try to understand, well, where are these cells? What is the nature of these cells that are bursting? Okay? But let me tell you something. If your brain was bursting or your heart was bursting, your problem wouldn't be an elevated LDH. It would be rapid neurological compromise or cardiogenic shock. So you know that some cells release LDH and cause much bigger problems than just an LDH elevation. But if you are focused on an LDH elevation in a patient who has normal blood pressure and normal mental status, it can't be the brain or the heart. So where can LDH come from? It can come from organs that have a tremendous reserve, such that even if you burst a lot of them, your patient is still stable. What are those organs? The liver, the kidney, the muscles, and the red blood cells. Okay? I just said red blood cells, right? And when you look and you see the patient's anemic, you're like, okay, I know for sure that there are cells bursting and the patient's hemoglobin is down. It's probably red blood cells. How do you then confirm that hypothesis? You look at the reticulocyte count. You see that despite losing so many red blood cells, your bone marrow is compensating by making much more reticulocytes. Okay, so the concept of an LDH equals cellular burst, but it's not all cells. It cannot be the brain and it cannot be the heart because your patient will be comatose or have hypotension. So it's either liver, kidney, muscle, or red blood cells. When your patient is anemic, you suspect that it's the red blood cells that are bursting. And when you see that there's a compensatory response from the bone marrow, you wonder that supports the idea that the red blood cells are being burst. So we have a hemolytic anemia. How do we know for sure? There's also an accumulation of the toxic product of hemoglobin accumulation. That hemoglobin is being converted into indirect bilirubin. So we know there are cells bursting, and because the hemoglobin is low, because the reticulocyte count is high, and the indirect bilirubin is high, we know that those cells that are bursting are red blood cells. Okay? So you take a look at that lab, you're like, cells are bursting because of the LDH. And which cells? If the CK was high, it would be muscle. If the liver enzymes were high, it would be liver. If the patient had flank pain, it would be renal infarction. But here, the patient has an anemia, elevated reticulocytes, and indirect hyperbilirubin. So why, my dear friends, is the patient hemolyzing? When you're worried about hemolysis, that's when you have to go swimming. Swimming in the river of blood. What does that mean? You are in a blood vessel, a nice, lovely red blood cell you are, minding your own business, and boom, you pop. The question is, why did you pop? Did you pop because the environment around you in the red blood cell is the problem? That is what we call a microangiopathic hemolytic anemia, like TTP or HUS. Much less likely because when the environment is the problem, you also cause thrombocytopenia. So isolated anemia is unlikely to be an environmental problem because the environment also destroys the platelets. Okay, let's go back to being that red blood cell again. You may be burst open not because of something in the environment, because of a vulnerability on the membrane of the red blood cell. Now, why would your membrane be dysfunctional? It's because most commonly you have an antibody attached to it. And that antibody can either be warm or cold, and that bursts your cell load. Other non-antibody issues related to membranes are things like hereditary spherocytosis, where you have a deficiency in the anchoring protein, an accumulation of lipids that can occur in the context of cirrhosis called Zeev syndrome, and a deficiency of complement protecting factors that occurs from PNH. So if there's a problem on the red blood cell membrane, it's either because there's too much antibody or too little lipids, too little PNH protectors, and too little anchoring proteins causing hereditary spherocytosis. Last but not least, you maybe have a problem in the red blood cell itself, not the membrane. And that problem can be because of an enzyme deficiency like G6PD, can be because of a hemoglobin issue like sickle cell disease, or it can be because something from the outside world came and took over your red blood cell. Something like malaria or babesia is in the red blood cell. So we know this patient has hemolysis. We know that because there's cells that are bursting in the form of LDH, and the hemoglobin is low, and the retic is high in the indirect bilirubin. We've now wondered, is it an environmental problem, a membrane problem, or an inside the red blood cell problem? Environmental problem, not happening. Why? Platelets are normal. An antibody problem? Probably not, because we didn't see the antibody on the Coombs test. The Coombs test is designed to pick up the antibody, and we didn't see that there. So we are either dealing with a non-antibody membrane problem, like hereditary spherocytosis or PNH, or we're dealing with something inside the cell, like an infection or an enzymopathy or a hemoglobinopathy. So the next key question is, what does the scene of the crime look like? The scene of the crime is to look at that red blood cell and study if there's something in it, like malaria, or if it takes a characteristic shape that tells us what happened to it. If it looks like a schistocyte, it tells us the problems in the environment. If it looks like a spherocyte, it tells us the problem is on the membrane. If it has something inside it, we have to find out what that something is, malaria or babesia. If it looks like it's sickling, whew, there's your answer. If it looks like it's had a bite taken out of it, oof, then we got to wonder, where is that G6PD? So we'll pass the mic to you to tell us more about the story of red blood cells so we can figure out what happened to it.
Okay. So hepatitis B and C screening was negative. ANA anti-nuclear antibody was also negative, and the levels of G6PD was normal. CD55 and CD59 was normal. Osmotic fragility test was normal. Yeah. And peripheral smear revealed no parasites. USG of the abdomen revealed a spleen that measured 16 centimeters in size, and moderate hepatic enlargement with normal portal vein diameter.
Oh my God, what did you just do to us? Wow, what an incredible aliquot. So let's study the value of these tests. I'm just going to go in reverse order. Well, I don't know why, because that's how it registered with me. So the osmotic fragility test is a test that's designed to study the probability of hereditary spherocytosis. And because the anchoring proteins are weak, the cell is vulnerable to bursting when it is confronted with a dilute solution. So if you have a dilute solution, blood is sucked out of the red blood cell and it bursts. The osmotic fragility test has imperfect test characteristics for hereditary spherocytosis. It's good, but it's not perfect. And a more specific test is what's called E5MA, eosin 5 malleate. It studies a specific anchoring protein that is very good for hereditary spherocytosis. So osmotic fragility test reduces but does not eliminate the possibility of hereditary spherocytosis. That's in contrast to the CD55 and 59, which are, again, the proteins that are deficient in paroxysmal nocturnal hemoglobinuria. Their absence makes PNH very unlikely. G6PD, The cool thing about G6PD is it is a self-fixing disease. G6PD deficiency is a genetic disorder that's usually X-linked that results in a reduced activity of the enzyme, making the red blood cells vulnerable to bursting in the face of stress. And if you get a stress in the face of G6PD deficiency, you will burst all your cells that are deficient in G6PD. And by the time that the doctor comes and tests you, all your G6PD levels are normal. So you often have to repeat the test after the resolution of the hemolytic crisis. So what progress have we made here? We've received one definitive test, which is the PNH testing. But every other test, the osmotic fragility test is imperfect for hereditary spherocytosis. The G6PD test is imperfect for G6PD deficiency. And most important of all, the parasitic screen is also imperfect for the detection of malaria. So now, again, you got to look at the smear because that will give you a clue of what happened, and you can back calculate what is going on now, potentially repeating the G6PD level afterwards or getting more advanced testing for hereditary spherocytosis. But most importantly, the most morbid diagnosis right now is not HS or G6PD. It's malaria, malaria, malaria. One of the most common infections worldwide. So keep that on your radar. All right, back to you, my friend.
Okay. So then we did a liver biopsy, which revealed chronic hepatitis changes with preserved architecture. So that rules out cirrhosis. The next one kind of gives it away. Okay, so we did a slit lamp examination.
Let's give the chat a chance to guess at it. So you're saying that the next alcohol will give us the answer? Okay, all right. Oh, what do y'all think?
Yeah, I think.
I'm going to pause here for maybe like 30 to 40 seconds and just let folks go through it. All right, y'all, I'm going to tell you what I think. I'm going to show you some things, okay? So, one, I think this is one of my favorite cases ever because it discusses a diagnosis. I think it makes me worry about a diagnosis near and dear to my heart. Forgive me for the real-time Evernoting that I just wanted to show you. So, where are we at? We're in a unique world here. The hepatomegaly, I think, has been the kind of elephant in the room here. Everything that we've talked about, by the way, does not explain hepatomegaly. Even the infection with malaria does not explain the hepatomegaly. And now we know something about the hepatomegaly. It tells us that this disease is chronic. So one very annoying thing is that hemolysis can hide in the face of liver injury. The AST goes up, the bili goes up, and all the markers of hemolysis. See how many times we mentioned the liver? We mentioned the liver with the hepatomegaly, we mentioned liver with the bilirubin, and hemolysis and liver stuff can get easily mixed up, masking diseases that cause both liver injury and hemolysis. So let me show you. This is a Evernote that I've been working on to try to make into a schema. It hasn't turned into a schema yet because it hasn't quite clicked. But if you have evidence of liver disease and hemolytic anemia, what diagnoses should you prioritize? Spur cell hemolytic anemia occurs in the context of cirrhosis, which is not happening here. We've talked about Ziv syndrome. Let's skip this for a second. Sickle cell hemolysis, much less likely in the face of normal sickling on the peripheral smear. Autoimmune hemolytic anemia and autoimmune hepatitis and autoimmune hemolytic anemia can occur together sometime, but the Coombs test is negative here. Coombs test is negative here, making UC and PSC less likely. And this patient does not have hepatitis E now because the evidence of chronic hepatitis on biopsy would not be compatible with hepatitis E. So let's go back to what my favorite schema on the CP Solver's website, which is hemolysis. And I'm going to show you something about hemolysis, two things about hemolysis. So, one moment. Okay, so this is what we talked about, right? Hemolysis, membrane, environment, or internal, okay? Environmental causes usually cause thrombocytopenia, much less likely here. Membrane causes God, we've looked so hard. No antibody, normal osmotic fragility test, normal. And this is not happening. We even got a biopsy to prove it. We're looking left, right, and center for malaria. We haven't found it yet. We haven't found this. And we've tested so much for this. You know the most important clue? I know, my friend, that you would have told us the scene of the crime by now if it were critical. I suspect that the scene of the crime, the peripheral smear, may have been normal. And what do you do when the smear is normal in the face of hemolysis? What diagnoses should you prioritize? Let's talk about that for a moment. So we are in the world of smear negative hemolysis, where we have not found the answer despite looking at the scene of the crime. Let's run some numbers. The environmental causes usually result in schistocytes. But schistocytes are only present in 50% of patients with DIC and in a small fraction of patients with macro angiopathic hemolytic anemia from valve issues or from foot strike. But again, we've talked about this causing thrombocytopenia, so that's not less likely. Membrane causes, remember, spherocytes only show up in 50% of cases of autoimmune hemolytic anemia, but the Coombs test is negative. We've ruled this out. A notorious cause of smear negative hemolysis is G6PD infection, but we talked about why that's likely. But electrolytes. Electrolytes are twofold, either hypophosphatemia or hypercopperidemia. And when you run this case through that lens, you're like, I have a young person with a smear negative, Coombs negative hemolytic anemia with a normal G6PD level, with a normal osmotic fragility test, who then has liver disease of chronic variety, you have to worry about Wilson's disease. So I'd really worry that that this patient is destroying his red blood cells because his diseased liver is periodically bursting and releasing copper, which makes those cells die. So I think in real life, you probably would be wondering about G6PD being falsely negative, about hereditary spherocytosis being missed with a more sensitive test. But you have to think about Wilson's and get a ceruloplasmin level, and maybe even study the liver biopsy for copper staining. I'm going to look at the chat now. Oh, it looks like the chat is on it too. And also wondering about malaria, syphilis. All these things in real life could totally end up with this case, but I'll pass the mic back to you to tell us more.
Okay, so slit lamp revealed presence of Kaiser Flasher rings. And then we measured serum ceruloplasmin, which was 8 mg per dl. And 24-hour urinary copper excretion was 132 over 24 hours. And a liver biopsy for dry weight revealed a copper concentration of 260 micrograms. And a brain MRI showed no signs of heavy metal deposition. So yeah, the diagnosis is Wilson's disease presenting as hemolytic anemia.
Ah, unbelievable. Wow. Whew, tell us more what you learned, how the patient did. This is just an incredible case. So tell us where you're at. How's the patient doing? What did you learn from it? This is unbelievable. Wow.
This was recent, so we don't know yet. But like he is on zinc and trying and like we still have to follow up.
That's incredible. Wow. Well, I hope he does well. Can you tell us more about what was your journey like being involved in this patient care? What did you learn? What stuck out to you?
I had no idea. I was thinking of enzyme deficiencies or storage disorders because I was hepatosplenomegaly. And obviously malaria and leishmaniasis were on my differentials because it's India. Yeah, so this was really fun when we finally got to the liver biopsy part.
That's incredible. Yeah, I have to tell you, there's a lot of reflecting to do in this case about how you can think through something as complicated as this. And I think that, you know, your evaluation was so thoughtful and indicative of the base rate, which is that sometimes the more common diagnoses have imperfect tests. And so you have to think long and hard about those imperfect tests before you invoke something rare. But at the end of the day, it's amazing how a glance in the eye can really be the pivotal test. And the slit lamp exam here was just absolutely crucial. I really hope that you take the opportunity to get this case on Human DX, as Travis was just saying. And there's so much here for all of us to learn. Thank you so much for presenting it today. It really is one of my favorite cases that I've had the privilege of discussing on VMR. Such a wonderful journey. And, you know, if caught early as you did, this patient has a very good chance of doing well. And so kudos to you for teaching us, but also for taking wonderful care of a patient who likely has a good prognosis. Alrighty, who's going to take the teaching points today? Good luck, Gurleen, my friend. Cannot wait for your masterclass. I'll pass the mic to you. Thank you all for joining us. It's been a delight, and I'm really excited to relive the journey with Gurleen.
Yeah, thank you so much for presenting that case. I learned so much, and I'll definitely have to rewatch it to catch everything. But just going over a little bit about the journey of the case. So initially, we were presented with the symptoms of fatigue and reduced appetite, and those symptoms in of itself are very nonspecific, even though they raise concern. So what was really more specifying in the symptoms was the discoloration, the yellowish discoloration of his eyes and skin, which points towards hyperbilirubinemia. So when we're thinking about hyperbilirubinemia, the bilirubin is really important to figure out if it's direct or indirect, and that helps us tell us if it's something that's pre-liver, intra-liver, or post-liver. So if it's indirect bilirubinemia, then we know it localizes to pre-liver, and that could be due to increased synthesis or decreased uptake in conjugation. The thing that needs differentiation is direct bilirubinemia, which can be due to intrahepatic causes or post-liver causes. So intrahepatic would be things that affect bilirubin formation and excretion, and post-liver, we're thinking about obstructive causes. So obstructive causes, is this something in the lumen, such as a stone? Is this something surrounding the biliary duct, so something like cancer, like pancreatic cancer, or is this something in the wall of the vessel itself, so like something like primary sclerosing cholangitis? And then when we're thinking in this patient, he presented with dark discoloration of the urine. That usually points towards indirect bilirubinemia in terms of hemolysis, but we want to always remember that if the patient isn't eating or drinking as much, as concentration of the urine can cause darkening, as well as direct bilirubinemia. Sorry, I meant to say direct bilirubinemia is usually what causes dark urine because it's soluble in the urine, but we want to remember that even indirect hyperbilirubinemia can cause pigmentation of the urine because of the hemolysis, which was the case in this patient, which had dark urine. And then when we're thinking about the other clues in this case as we were unfolding it, the major thing was the splenomegaly and the hepatomegaly. So when we're approaching splenomegaly, we're thinking about what is filling up the spleen. So it could be due to water, things like portal hypertension, and that would also be seen as hepatomegaly, but you would see those manifestations on the physical exam itself with signs of ascites and things like that. The other things that could cause splenomegaly would be molecules, so things like amyloid deposition of lipid storage diseases like Gaucher's disease. And then the other aspect would be red blood cells or white blood cells. So when we're thinking about red blood cells, things like sickle cell disease or autoimmune hemolytic anemia, and then white blood cells, infection, autoimmune causes, malignancy, including myeloproliferative disorders or drugs. And then we wanted to layer that on top of the hepatomegaly. When we're thinking about hepatomegaly, portal hypertension can cause both splenomegaly and hepatomegaly, or things such as molecule deposition or white blood cells. And then the really specific point of this case is the indirect hyperbilirubinemia, which allowed us to kind of hone in on different things. So when we're thinking about indirect causes, is there increased delivery of bilirubin? So things like hemolysis or hematomas. Is there decreased uptake like congestive hepatopathy or portosystemic shunts? Or is this decreased conjugation due to genetic disorders like Gilbert's syndrome or hyperthyroidism or medications? And in this case, the elevated LDH, when we're thinking about that, there's different organ systems we want to keep in mind. So things such as liver, kidney, muscle, or red blood cells would lead to cell lysis, and those would lead to elevated LDH. And when we're layering in with the anemia, we're thinking about red blood cells, especially with the elevated reticulocyte count. And then in terms of hemolytic anemia, when we're approaching it, there's different ways to think about it. And those were the different tests that we had in this case that helped us narrow down. So when we're thinking about the environment, we usually see schistocytes on the smear in things such as MAHA and DIC, but we want to remember that's only in 50% of cases. So you can still keep a suspicion of that if you're thinking, even if there's no schistocytes. And then the other aspect would be membrane causing hemolytic anemia problems, things like autoimmune, hereditary, spherocytosis. In this case, there was a negative osmotic fragility test, which can miss cases of hereditary spherocytosis. So something that's more specific is the eosin 5-MB test. And then other causes that could affect the membrane and cause hemolysis would be things like cirrhosis or Zeev syndrome or PNH. And then thinking about intrinsic causes of hemolytic anemia would be infections such as Babesia or malaria, as well as enzyme deficiencies like G6PD deficiency, and then hemoglobinopathies. And then in this case, when we're thinking about, there is an overlap between liver disease and hemolysis. So liver disease can often mask the symptoms of hemolysis, so that's important to remember. And things you would think about would be cirrhosis, Zeev syndrome, and Wilson's disease. And in this case, when we're thinking about smear negative hemolysis, you want to remember, as I was mentioning, that only 50% of cases for DIC and MAHA, you would see evidence on smear. But in this case, those things were less likely because you had normal platelet counts. When you have an environmental cause of hemolytic anemia, you usually see anemia with thrombocytopenia. So that pointed us away from environmental causes. And then other things were things like G6PD. In this case, most of those exams from the labs were normal, so it was less likely. And then the other thing to keep in mind with smear negative hemolysis is electrolyte things. So that would include hypophosphatemia or hypercopper, which we see in Wilson's disease, which led us to the final diagnosis. There's definitely a lot to unpack, and I definitely have to go back and rewatch all the pearls. Thank you so much for presenting this case, Sharanya.
Geraldine, Sharanya, this was just a delight. Geraldine, your recap is superb. That was really, really just so well done, and a great, concise analysis of all the things we reflected on. And Sharanya, thank you again. This is truly a VMR favorite for me, and I think the vibe from the chat is they felt similarly. Thank you so much for bringing such a wonderful case to us, and hope to see you regularly on VMR.
Thank you so much. I had so much fun.
Bye, all. See you soon.